Bismillahirrahmanirrahim. Diseases of sebaceous glands. We will talk first about the sebaceous gland. The sebaceous gland, as we see in the figure, we will talk about it with many items: structure and physiology, composition, types of pilosebaceous follicles, functions of the sebum, and endocrine control. Structure and physiology. The sebaceous gland is a holocrine gland with secretion from complete destruction of the cells. The time from formation to the discharge is 7.4 days. So it's a holocrine gland, meaning the secretion from complete destruction of the cells. It consists of many lobes and each with a duct lined with stratified squamous epithelium. The duct ends in the main duct. All converge into the pilosebaceous canal, which open into the surface epidermis. So there is the lobes, and with their duct that opens into the main sebaceous duct to the pilosebaceous canal, and its epithelium continues with the surface epidermis. The distribution, they are all over the skin surface, except the valves and soles, and the vermilion border of the lip and glands. They are especially found in the face, forehead, midline of the back, where are they large and numerous, usually in this size 400 to 900 gland per square centimeter, and elsewhere it is less than 100 square centimeter. So they are all over the body surface except palms and soles, vermilion border of the lips and gland, and they are especially in the face, forehead, and midline of the back. The free sebaceous glands, they are not with hair follicle. They open directly into the surface of the skin. Example, meibomian gland of the eyelids, Tyson's glands of the prepuce and female genitalia, and areola and nipple. There are free sebaceous glands. The development intrauterine, it occurs in 13th to 15th of intrauterine life, and there is as budding cells, and it is from primordial follicle epithelium, from 13th to 15th of intrauterine life. And the sebum, which is the first glandular product of human body, in intrauterine life it is regulated by maternal androgen, and in neonatal period it remains active, and early childhood till puberty it involutes. At puberty, they undergo enlargement and increased sebum production. So there is intrauterine life regulated by maternal androgen. In neonatal period, they remain active. Early childhood to puberty, they involute, and at puberty, they go enlargement and increased sebum secretion. The composition. The sebum is a complex mixture of lipids. There is the skin surface lipid consists of sebum and epidermal lipids. The epidermal lipids, which is the lipids from keratinizing epidermis, consists of triglycerides and the free fatty acids and the cholesterol and cholesterol esters. And the sebum, it forms triglycerides, wax esters, and squalene. The wax esters and squalene is only by sebaceous glands. So this forms the skin surface lipids, the epidermal lipids, which is the lipids from keratinizing epidermis, free fatty acids, cholesterol esters, and the sebum, which forms the triglycerides, wax esters, and squalene. This is the composition. And also there is a note that sebaceous glands do not convert squalene to sterols. In epidermis, squalene synthesized in lower layers, they are rapidly and totally converted into steroids, either vitamin D precursors or cholesterol. Also, the squalene is unique to the sebum and to humans. We'll shift to the types of pilosebaceous follicles. The pilosebaceous follicles, 3 types: terminal follicles, sebaceous follicles, vellus follicles. The terminal follicles, they are characterized by long, coarse terminal hairs, and the site in adults occurs in scalp, eyebrows, beard, axilla, and pubis. While the sebaceous follicle, they are characterized by, they are from rudimentary hair follicles, forming fine hairs, so they cannot withstand sebum production, with large sebaceous gland. And they occur usually in the face, sternal region, shoulders, and upper back, where the sites of acne are. And the vellus follicles, they are fine, soft hairs covering most of the body of youngsters. They usually convert at the onset of puberty into sebaceous follicles or into terminal follicles. Of course, the acne doesn't develop in the terminal follicles because there is powerful erecting hair allows the excretion of sebum, and in the sebaceous follicles they develop, of course, and in the vellus follicles, according to the type, they will shift to. So the types of pilosebaceous follicles is terminal follicle, sebaceous follicle, vellus follicle. Terminal follicle, large coarse terminal hairs. Sebaceous follicle, rudimentary hair follicle with large sebaceous gland. Vellus follicle, fine soft hairs covering most of the body of youngsters. The site of the terminal hair in adults, the scalp, eyebrows, and beard, axilla, and pubis. And the site of sebaceous follicles of the face, shoulders, upper back, and sternal region, where the site of acne are. And here the vellus usually at the whole, the most body of the youngsters. And the acne, it doesn't develop in the terminal hair, but it develops in sebaceous hair, and in the vellus hair, according to the type, it will shift to. The functions of sebum. The functions of sebum: moisture and control moisture from loss from epidermis, and protective value, and also the organisms. They are against fungal and bacterial infection of the skin due to free fatty acids. This is why ringworm rarely occurs after puberty. So they have this function of moisturizing, protecting, and also against the organisms as fungal and bacterial infections. We can measure of sebaceous activity by using a pad of cigarette paper on the area of the forehead for 3 hours. Then sebum is extracted with diethyl ether. So this is the types and function of the sebaceous glands. And the endocrine control, you can see here the figure. The sebaceous gland is affected by, to the right, androgen, progesterone, pituitary hormones. This is stimulatory action, and the inhibitory action by estrogen, glucocorticoids, oral retinoids, and anti-androgens as cyproterone acetate. The endocrine control, the androgen, of course, it's an androgen target organ. Dalil and testosterone administration increase the size of the gland and sebum output in prepubertal boys, but in adult males, not in adult males. This happens in prepubertal, but not in adult males, because glands undergo maximum stimulation of endogenous androgen. The sebaceous gland activity varies from follicle to follicles, and different sensitivity to androgens, because of different sensitivity from follicle to follicle. This is due to androgen receptor variability, and also local levels of 5-alpha reductase enzyme. The progesterone, of course, there is no clear effect, but in very high doses it causes stimulation of sebaceous glands. The pituitary hormones increase the activity of sebaceous glands directly or indirectly by releasing gonadal, adrenal, and thyroid hormones. And also the estrogen, it decreases the activity directly on sebaceous gland, and indirectly, especially indirectly, by decreasing endogenous androgen production. The glucocorticoids decrease the activity of sebaceous gland directly and especially decreases the adrenal androgen production. So this is the endocrine control of the sebaceous gland. Androgen, progesterone, pituitary hormones, estrogen, and glucocorticoids. Androgen it's an androgen target organ, increase the size of sebaceous gland, and the progesterone, it increases the in high doses the sebaceous gland stimulation, and pituitary hormones increases the activity directly and indirectly, and the estrogen and glucocorticoids decrease the activity directly and indirectly. Acne vulgaris. We'll give an introduction in acne vulgaris about epidemiology, etiopathogenesis, and resolution of acne. The acne vulgaris, it's a chronic inflammatory disorders of pilosebaceous apparatus characterized by comedones, papules, and pustules, nodules, cysts, and sometimes scoring. It's a chronic inflammatory disorder of pilosebaceous apparatus characterized by comedones, papules, pustules, nodules, cysts, and sometimes scoring. Epidemiology. It starts in generally, it starts in adolescence, 12 years, and resolves in mid-teens, around 25 years old. 85% of acne people. The peak is in 14 to 16 and in females, and 16 to 19 in males. The etiopathogenesis, the acne initial pathogenic condition is the microcomedones. So the pathologic condition, the initial pathologic condition is the microcomedone. The true acne is different than the acneiform eruption. The true acne characterized by follicular eruption of comedones, which initially leads to inflammatory reaction and results in papules, pustules, and cysts. But the acneiform eruption, there is, as rosacea and spheroid acne, they are clinically similar to acne, but completely bypassing the comedonal stage. So the initial lesion is inflammatory lesion from the start. So the initial pathologic acne for true acne is the microcomedone. The acne vulgaris is a multifactorial disease with four main etiopathogenesis or etiopathological factors. The first is increased sebum production. Second, ductal hyperproliferation, comedones. Third, proliferation of Propionibacterium acnes. And fourth is inflammation. Sebum production, ductal hyperproliferation, comedones, proliferation of Propionibacterium acnes, and inflammation. The sebum production, as we can see here, the sebum production, it is due to hyperresponse of the gland to normal levels of plasma androgen. This happens at puberty. As clinically, patients have acne in some but not all sebaceous sites. And also there is no increase in androgen levels in all patients. So the sebum production occurs due to hyperresponse of the gland to normal level of plasma androgen. The second thing is the ductal hyperproliferation, comedones. The increase or accumulation of ductal corneocytes due to increased formation or inadequate separation of the ductal corneocytes. The ductal cornification results from androgen stimulation and irritant effect of sebum, especially squalene and squalene oxide. There is decrease in essential fatty acid, linoleic acid in sebum, demonstrated in comedones. That decrease is reversed during isotretinoin or cyproterone acetate treatment. So the second thing is ductal hyperproliferation. The third thing, or etiopathogenesis, is proliferation of Propionibacterium acnes. Blocked sebaceous follicle leads to increased anaerobic microenvironment, leads to Propionibacterium acnes colonization and leading to inflamed acne lesions. So there is the blocked sebaceous follicle leads to anaerobic microenvironment, Propionibacterium acnes colonization, and inflamed acne formation. Fourth factor is the inflammation. It was thought that Propionibacterium acnes secrete lipase that convert triglyceride to free fatty acid, leading to erosion and disruption of the follicular wall, lead to escape of follicular contents to the derms, leading to non-specific inflammation. However, it was found that ductal response is not necessary, ductal rupture is not necessary to initiate inflammation. There is 80% of early inflamed acne occurs without rupture of the duct. So the inflammation actually is two types, as we will see here. There is early inflammation and severe non-specific inflammation. So we will talk about the two stages of inflammation, or the pathogenesis of inflammatory acne. The early inflammation is related to Propionibacterium acnes. It makes three things: activation of toll-like receptors, lipase secretion, complement activation, and chemotactic factors. We will talk about chemotactic factors. Propionibacterium acnes release chemotactic factors which within the duct, which diffuse into the derms, leading to neutrophilic migration, reactive oxygen species, and inflammation early. So as we can see in the figure, it releases chemotactic factors, neutrophilic migration, lysosomal enzymes, collagenase, and this leads to early inflammation. Within 24, first actually there is early inflammation, there is lymphocytes which are involved in this early inflammation, and within 24 to 48 hours the polymorph nuclear leukocytes become active. There is also complement activation is evident early in early stages of inflammation. Severe non-specific inflammation, the second thing, this occurs due to rupture of follicular wall and escape of follicular contents into the derms, leading to severe inflammation. So there is the early inflammation and the severe non-specific inflammation. Actually, the inflammation is a not abnormal response of immune system. It is actually a normal immune and non-immune response to a foreign substances penetrating derms. So ductal corneocytes secrete interleukin 1 alpha and interleukin B and tumor necrosis factors, which may be involved in the acne inflammation. This is the two stages of inflammation we were talking about. So we have 4 etiologic factors: increased sebum production, ductal hyperproliferation, proliferation of Propionibacterium acnes, and inflammation with its 2 stages. What about the role of bacteria in acne? Of course, here we're talking about, from down to up, the Propionibacterium acnes, which is anaerobic. They are immotile, grows deep in the sebaceous follicle and carried into the skin surface by flow of sebum, actually. It mobilizes triglycerides to sebum. The second thing is petrase oval or orbiculaire. They residue in the upper portion of acroinfundibulum of the sebaceous follicle, and the staph epidermidis aerobic that residue on the skin surface. So this is the role of bacteria in acne. Propionibacterium acnes anaerobic, immotile, grows deep in the sebaceous follicle and carried into the skin surface by flow of sebum. It mobilizes triglycerides to sebum. Petrase oval or orbiculaire in the upper portion of acroinfundibulum or sebaceous follicle. Staph epidermidis aerobic on the skin surface. What about the acne resolution? The acne resolution, in most cases, acne resolves in early adult life. The reasons are not decreased sebum production or surface bacteria, but it may be due to change in the response of follicle to the androgen, which no longer produce inflammation. Other factors of etiopathogenesis, there is another things rather than the 4 key factors. There is another things as genetic, premenstrual flare, stress, diet, and ultraviolet rays. Genetic, there is positive family history often. Premenstrual flare, 70% of females. Stress may increase acne. Ultraviolet may increase and sometimes decrease acne. And the diet, before they said that there is no failed to prove, but now there is certain foods that increase the acne formation. Actually, there is the Corynebacterium, there is the Propionibacterium acnes and Staph epidermidis involved in the acne, and there is the Corynebacterium minutissimum in erythrasma and pitted keratolysis, which occurs in soles, and Trichomonas axillaris. This is a note about Corynebacterium.